My name is Gaurav Choudhary. I'm a cardiologist in Providence, Rhode Island. I'm a professor of medicine at Brown University, Alfred Medical School of Brown University, as well as I'm director of cardiovascular research at Brown University Health. I got interested in pulmonary vascular disease because of some incredible mentors that I found here who were working on pulmonary vasculature, pulmonary vascular endothelial cells, and with my background in cardiology and got interested into pulmonary vascular remodeling, pulmonary vascular endothelial cells, and pulmonary hypertension. As a practicing cardiologist, I used to read echocardiograms all the time and would see people come in with elevated tricuspid regurgitation jets or elevated pulmonary artery systolic pressures on echocardiogram. And we would do this often and then put it in our report and hope something happens with the results. And more often than not, those observations, this was 15, 20 years ago, were kind of there reported but not acted upon in most of the cases. It was one of the things that was part of the echocardiography report, but nobody really paid attention. And that got me thinking that, okay, we're doing this. We know, at least from some of the literature, that these PASP is bad. Elevated pulmonary artery systolic pressure is bad, but there's nothing happening. So I dabble both in epidemiological studies and clinical studies as well as basic science studies. My day job is actually running a lab looking at right ventricular dysfunction and mechanisms to improve right ventricular function using a lot of preclinical models and biological specimens. But in the epidemiological side, that's where we kind of started off because first we wanted to define the problem in some ways. So we looked at databases with collaborators from here in Boston and then saw, okay, how common is elevated PA systolic pressure? And what is the impact of having elevated PA systolic pressure? We found in the BA population first that there was a large number of people who were undergoing echocardiograms had elevated PA systolic pressures. Now, we cannot diagnose pulmonary hypertension by echocardiogram, as all of us know. We need a right heart catheterization for that. But it's a pretty good suspicion that if you have high PA systolic pressure, your probability of having elevated mean PA pressure is high. Thresholds kept getting debated on, and we have contributed our own to the literature about the thresholds that may be meaningful to diagnose pulmonary hypertension. So it's very under-recognized. So that was some of our initial work, and then we used a national databases to look at what's the impact of elevated mean PA pressures on outcomes, and we found that as early as mean PA pressure of 19, we start seeing poor outcomes, and then we expanded some of that work with PVR and wedge pressure. So that was kind of the epidemiological area. But the other problem of under-recognition when we talk about it is once you have an echo, you see a PA pressure, and nobody acts on it. But not everybody gets an echo. And we have all these people who have dyspnea. People in the PH community are well aware of the delay in diagnosis in pulmonary hypertension, because of the non-specific symptoms that come before. And if you go to primary care doctors, you go to specialists, and there is a well-known documented delay. So how can we see if we can act earlier? And one of the things that I was always curious about is using tools that we use every day, but using it better for that particular purpose. And the stethoscope has been around for 100 years. Unfortunately, what goes between the stethoscope is getting worse and worse as far as the skill is concerned from our trainee perspective. And that's also well documented. And there has been a real decline in understanding what you're hearing through a stethoscope. And all the major societies have realized that and actually published data. Unfortunately, and again, this is not a generalizable statement, so not all people are that. But in primary care, it's a little bit worse than in specialty care, which is understandable, especially when it comes to cardiac auscultation. And cardiac auscultation is one of those things that has been used clinically to suspect diseases like pulmonary hypertension. The idea was, okay, can we now use cardiac auscultation and see if the new technology of deep learning and convolutional neural networks develop an algorithm which can suspect elevated PA pressures. I was interested in it and, I was trying to say, okay, how can we do that? And I looked up online to see if there were any things already there, looked up the published literature. And then I came across a company which was working on digital stethoscope, and they had some early algorithms out on murmur detection already. And I just reached out to them and then said, okay, this is something that we want to do. This is important. they realized the importance of pulmonary hypertension in general. And now I'm not talking PAH, I'm talking about pulmonary hypertension in general, and got interested in it. So we did a pilot study first, which we just published, I think last year in Journal of American Heart Association, in which we first developed an algorithm. So we used about 6,000 patient data points where they had an echocardiogram and phonocardiograms. We knew the PA systolic pressure in these patients from all over the world. And then we had around, I would say, 170,000, 169,000 just phonocardiograms without known PASP. These inputs were used to kind of train an algorithm to detect PH, and we took a threshold of PASP of 40. So again, we took the phonocardiograms. They basically, little recordings, audio recordings. They're converted into what's called a MEL spectrogram, which is an easier way for the computer to read it. There's small stretches of it that are cropped, and after they're cropped, they're put into an algorithm to train. We basically take 80% of the data to train it, and then 20% to validate it. And this happens in 5-fold cross-validation. And then the output comes at whether they say, okay, did they meet the threshold of 40, so PH or no PH. So once we trained the algorithm, we got, about an average ROC curve of about 0.8. So about 80% area under the curve. So then we wanted to validate it, right? So because, it can function really well on the data that you give it, because the diagnosis perfectly because of that. So we had about 200 patients who came in for a regularly scheduled echocardiogram. We did the recordings on them and we put it through this model. And again, we got about a sensitivity of about 78% and a specificity of about 70%. So pretty reasonable. Now, these were pretty small numbers, 196, 200 patients. So it is feasible. It's doable. The output right now would come as either normal or suspect PH. There were several limitations in our initial study. Obviously it was at a single center. Most of our patients, because of the nature of the population that we were doing, were men, so very few women. They were older. We did a number of ways. We did the analysis. We did a per patient analysis where you take 5 recordings on a patient and then average it out and see PH or no PH. Or you can do it per recording, so in each of the 4 or 5 areas, whether it's PH or no PH. So there was still some work to be done because at the end of the day, we don't care which area it is coming from. We care whether the patient has PH or not, right? So or suspect PH in patient. The other issue is our gold standard in this case was an echocardiography. And we all know the gold standard for diagnosis of pulmonary hypertension is the right heart cath. So based on this preliminary data and these new questions, we actually submitted a SBIR grant to the NIH to get funding for a larger study, which is currently ongoing. I'm an MPI on that because it's an SBIR grant. ECO, which is the Stethoscope company, they have a PI on that. And so it's a collaborative project. So now we're enrolling about 2,000 patients who are coming in for echocardiogram. Plus, we're enrolling patients who are just coming in for right heart cath. So we have both cohorts. And then kind of further refining these algorithms. Because one of my concern always has been that if you take a threshold, whatever threshold you pick, 40, PSP, to train the algorithm, you don't want the algorithm to overdiagnose, because what happens is it's like the false alarm. If I'm a clinician, a busy clinician, primary care practice, I'm seeing a patient and it keeps saying every third patient I see that suspect PH, and I send a few of them for an echo and nothing comes out of them, I'll stop using it, right? So what we also want to know is not only the accuracy, but also maybe the severity, right? So we want to know is, okay, it's maybe mild, moderate, or severe. Because that kind of triggers different things. Maybe in mild, you do certain other things. While in severe, they may need urgent evaluation. So one of the things we are going to try to do is refine the algorithm so it can give us some categorization of the severity of the disease. We will validate it with the gold standard right heart catheterization. And then also we will have a larger number of patients to kind of further refine and improve on the AUC. So that's the goal for the next. The study's ongoing. It's in its second year. We probably have another year and a half to do. And obviously, one of the great things about partnering with a company that has a product like this is it can come to fruition really, really fast because they can go to the FDA, they can get it incorporated into the current suite of algorithms, and we can see the light of the day. This was really exciting to me because not only we can get something to the point of care in the hands of primary care patients. This is also direct to consumer too. So there you can buy a stethoscope yourself, though I wouldn't recommend interpreting what you hear from it. But you can look at it in remote care settings. You can look at places which are under-resourced. There's a lot of PH in sub-Saharan Africa, South America. Echocardiograms are not available at all places. So how can we further ensure that people who really need echo are identified in the field or in practices out there, and then they can go to a specialty centers. I think there could be a lot of potential for a technology like this to be implemented to improve the diagnosis and detection of pulmonary hypertension. But this is not the only technology in AI, right? People are using AI in pulmonary hypertension for detection purposes, like we are. They've used ECG. There are very nice algorithms coming out of Mayo and other places where they have looked at diagnostic accuracy or detection for pH. The different gold standards, echoes or right heart cath, CT, echo, and MRI, not only for detection, prognosis purposes, but also further subdividing which group of pH it may be, or in some cases, automatically coming up with an EF or right ventricular function or segmentation in some of these things, looking at lung vasculature using AI in CT and segmenting it. So there's a lot of work that's being done in other technologies as well. The reason I liked Stethoscope is because you don't need any big equipment, right? It's something that you carry with yourself, and most physicians have it or clinicians have it, and you don't need any setup for that. Or you do need internet connection for it to go to the cloud and tell you what the results are. That's why I kind of got interested in this AI project. That's where we are. I have always believed that AI is going to be here to stay. We have to embrace AI. We not only have to embrace AI, we have to work with the technology companies to make tools that are meaningful for our patients, because we are in the best position and the patients are in the best positions to help develop the tools that are useful for them. So we have to define the questions and we have to understand the limitations. It's really, really important. That was the example I gave you earlier. Is if every second patient on the primary care, it says suspect pH or suspect murmur or flags it, we have to be really making sure we are asking the real clinical question. Half of the echocardiograms have pulmonary hypertension or elevated PASP. The large databases have shown that 80% of heart caths have pulmonary hypertension. Now, they don't have pulmonary arterial hypertension, but they have pulmonary hypertension. So how do we make sure that we're getting the right kind of people for right kind of therapy? So I think this is the first step. And I think we need to be very careful about moving too fast in it, right? So this is the first step. But this is an exciting step because we're able to do what we weren't able to do before, right? So I'm hoping the next steps are going to be faster. It will need a larger population, because wouldn't it be great, and this is speculation, we put the stethoscope or we use an AI tool on somebody and it'll tell, well, this looks like pulmonary arterial hypertension. High mean PA pressure is suspected. We're not there yet. But right now, we're using only one tool. But just imagine how if we combine what we're seeing on one AI tool and combine it with a variable tool, combined with the data from your EMR, which a large language model has already processed, and you put it all together, and that would increase your confidence. Things that we cannot see in a 15-minute visit, that may be available to a primary care doctor and is flagging it from these multiple things. Or you have a chest x-ray which had an enlarged PA that nobody paid attention to, and then suddenly that also becomes pieces of it. The promise of this technology is that it will bring together data, synthesize data from multiple data streams for you to look at. And then the final decision, I think, has to be with the clinician and the patient, right? Because at the end of the day, AI is not going to replace the clinician. I think it'll augment the clinician. And I think there will be clinicians who will be using AI to help provide better care. That's the way I think about it. Now, patient-clinician relationship or patient-provider relationship is something that cannot be replaced by a machine. It's so nuanced. It doesn't matter what an algorithm says. It doesn't matter what the next titration dose need to be. It matters on what's going on, that you need to take care of. So taking care of patients is more than just following protocol. And I think that will not get replaced. So I think these will be tools that will assist us. Yes, that is a promising future. I think we will get there. I have no doubt. But I think we have to really be careful and engage with the companies and the people who are making these tools incorporate feedback not only from clinicians, but even from patients, especially from patients. One of the studies we proposed, it didn't get funded, but basically looking at implementation. Because you right now will have so many tools in AI that everybody's coming up with their diagnostic tool for disease A, B, and C. I gave you an example of what we're working on, but there are other examples even in the pH space, right, that have come up with, and they have excellent diagnostic accuracy in the studies. But then how do we implement it in a patient care setting? What is the acceptability from the patient? What is the acceptability from the providers? What is the acceptability from the nursing staff that's going to be using it? When you implement it, do you really change the trajectory of the course of that patient's disease, right? Do you detect early? And if you do, what are the extra tests that happen? How important it is? And do you start treatment early? Because at the end of the day, that's what we want to see. It's not that you have a tool that gives you 99% diagnostic accuracy. You want a tool that gets the patient treatment faster. The second phase of studies have to be moving beyond just testing area under the curves, but testing, if I implement this tool in a practice setting, am I making a difference to the patient? And those are difficult studies to do. Where we are at the first step of just defining these tools. But I think we have an exciting time ahead as we implement them in the future. Thanks for listening. My name is Dr. Gaurav Choudhary, and I'm aware that my patients are rare.